Welcome everyone. We are talking about post-resuscitation care. I mean the care that is done after return of spontaneous circulation of a cardiac arrest patient. So after return of spontaneous circulation, what you do, what the care you provide influences the outcome of the patient greatly. So it means that the learning outcome you need is what is the continued resuscitation that you do after ROSIC? What we mean by post-cardiac arrest syndromes? How to transfer a patient safely to ICU or to other hospitals? What are the limitations of assessing the prognosis? What are the difficulties you face prognosis after a cardiac arrest? We have a chain of survival composed of 4 circles. The first circle is recognition early recognize if a patient have a grave sign or symptom or have abnormal vital sign, and then call for help in order to prevent cardiac arrest happening. This is before cardiac arrest. Then if a cardiac arrest happen, you have to start CPR as early as possible to buy time, then early defibrillation in order to restart the heart. This is during cardiac arrest. Then if the patient returned of their spontaneous circulation, ROSIC, you have to start a care which is called post-resuscitation care. This is to restore the quality of life. So patients who have a bad sign and then go cardiac arrest, only 10 to 20% have chance to return to spontaneous circulation. It means best is to prevent cardiac arrest by early recognition and call for help. But if return to spontaneous, what you do to prevent this cycle happening again, going to cardiac arrest again. In this way, if a patient have early recognition, early signs and symptoms, do ABCDE to detect what's wrong with the patient and provide a good resuscitation. During cardiac arrest, the actions are to call for help and confirm cardiac arrest, and then start CPR and giving DC, drugs, 4H40, things like that. If the patient return to life, you have to do ABCDE again in order to detect what was wrong with the patient and what happened. So the aim of the post-resuscitation care is to restore the normal cerebral function and cardiac rhythm and cardiac function again, to provide a good organ perfusion and have a good quality of life after cardiac arrest. We have a syndrome called post-cardiac arrest syndrome, composed of 4 different things. First, post-cardiac arrest brain injury. The patient may be in coma, get multiple seizures, have myoclonus, have different brain injury problems. But this could be temporary and could be permanent. Post-cardiac arrest myocardial dysfunction. So the heart will fail, there will be heart failure, there will be different types of arrhythmia, there will be bad perfusion to organs, you have to support the heart. It might be for 2 to 3 days, then the patient improve. We have another syndrome called systemic ischemic reperfusion syndrome. This is like a sepsis in which the patient will be having high heart rate, fever, high white BC. So this is due to reperfusion of the organs that are already ischemic. Number 4, persistent of precipitating pathology. Example, you have a patient with chronic renal failure and the patient have hyperkalemia. So you have gain ROSIC, but then you need further actions in order to prevent the recurrence of cardiac arrest. So what you do, you have to do ABCD. First, starting with A and B, you have to ensure a clear airway, a protected airway. You may need a ventilatory machine and provide endotracheal tube, provide good oxygenation to the patient. So we may provide tracheal intubation, sedation, and controlled ventilation, especially if the patient is unconscious or Glasgow 8 and less. You have to maintain oxygen between 94 and 98%. In a patient with COPD, you may maintain between 88 and 92. Capnography to detect CO2 is important. Avoid hyperventilation. Then you have to look, listen, feel for both airway and for the breathing. Consider tension pneumothorax. Consider collapse of the lung, pneumonia, consolidation, wrong bronchial intubation. For example, this is trachea and these are the bronchi. When endotracheal tube is inserted, sometimes you may go and bypass that and go just to the right side. This is called bronchial intubation. So you have to withdraw that until you reach the carina to provide oxygenation to both lungs. Pulmonary edema due to heart failure, aspiration due to unconsciousness, fractured ribs or even flail segment during CPR. Insert a gastric tube to decompress stomach to improve lung compliance, because gastric distension can impede the diaphragm to do a good ventilation. Secure the airway, especially during transfer. Consider immediate extubation of endotracheal tube if the patient is breathing and having normal conscious level. So if the patient have normal conscious level, you have to do extubation. About the heart circulation, check the pulse and blood pressure and capillary refill time. And there might be distended neck vein which indicating right ventricular failure. There might be features of pulmonary edema indicating left ventricular failure. So you have to do ECG monitoring and 12-lead ECG and echo. For disability, for D, you have to do Glasgow Coma Scale. Look for the pupils for signs of increased intracranial pressure, for pupillary dilatation. Check the limb tone and movement, lateralizing sign. Check the posturing of the patient to detect what is the patient suffering from. So you have to check the eyes and verbal and motor component of the Glasgow coma and document that. Further assessment is history. You take the history from the family of the patient, from those who were with the patient during cardiac arrest, or from the patient himself if he returned his normal conscious level. You have to do further monitoring, further investigations. So what history is important? It might be you take a sample history. You ask for the signs and symptoms, any allergic reactions to any drugs, history of allergy, medications that the patient is used, and past medical history and pregnancy for females of childbearing age. What was the last meal the patient has taken? What was the environment? How was the event happened? So important features to ask in history also, what was the health of the patient before cardiac arrest? For example, a patient is already bedridden and crippled. After cardiac arrest, you may expect to have the same condition. Time delay before resuscitation. How much time done before resuscitation and duration of the resuscitation. These two greatly affect the prognosis of the brain function and neurological function. What was the cause of cardiac arrest? What was the family history? Was there any family history of sudden cardiac arrest indicating a congenital cardiac or any other problems? Monitoring vital sign, the ECG, pulse oximetry, and also blood pressure through arterial line if possible, CO2 measurement through capnography, the urine output of the patient to indicate renal function, the temperature of the patient. All these may influence the further management. Doing further investigation. IBG is very important, especially for acid-base and blood and also oxygenation components. full blood count looking for wide BC hemoglobin, biochemistry including blood glucose, troponin for acute coronary syndrome, ECG, 12-lead ECG to search for any ischemia, for any congenital arrhythmic effects, example, long QT interval, or hypertrophic obstructive cardiomyopathy, chest X-ray, echocardiography, all these can detect what was the problem and what was the complications. If you want to transfer the patient, you have to discuss with the admitting team, whether from the other hospital or from the same hospital that you admit, for example, in the ICU. You are talking with the intensivist or with the anesthesia doctor. You have to check your cannulas. Don't send the patient for other department without cannula. Check the drainage. If you already not done, do it. For example, Foley's catheter, NG tube, this should be secured as well. During transfer, you have to have a suction, an oxygen supply, for example, inside the ambulance. Monitor all what have you done, monitor and document what have you done. Reassess the patient before leaving, because if the patient deteriorated, you may not be able to transfer. You may not be able to intervene during your journey inside the ambulance. Talk to the family what's your plan. Talk to the family what happened, what is next plan, but don't tell them the prognosis, because prognosis is very difficult. Although this lecture is much about post-care, but this is also something talking about RCU. In the RCU or in the ICU, the patient may be under ventilatory machine and having tubes, endotracheal tube, and maybe they are supported with some inotropic agents through the pump infusion, maybe insulin, those inotropic to support the heart. The defibrillator machine and pacing are already there in order to support the heart. Sometimes intra-aortic balloon pumping for patients with heart failure as an interim measure until they do further management. The patient cannot eat. Enteral feeding, like for example, total parenteral nutrition might be started. Machines for cooling of the patient in advanced ICUs is good to provide a temperature between 32 to 34 in order to prevent neurological dysfunction. Optimizing organ perfusion for a post-cardiac arrest syndrome or ischemic reperfusion injury, you have to know that there might be reversible myocardial dysfunction for up to 2 to 3 days. There might be arrhythmias, then they improve. So you have to manage during this time by giving inotropic agents. So you have to do, for the heart, you have to do echo to measure the cardiac output. You may use inotrop balloon pump in order to provide a good blood pressure, to provide good urine output, and normalize lactate concentration, which may be raised during cardiac arrest. Other thing is, for the brain, you have to provide normal blood pressure, because brain needs a normal blood pressure. If there is unconsciousness, sedate the patient. If there is seizure, prevent seizures and stop the seizures by diazepam, by other benzodiazepines, also by Keppra, levetiracetam, by phenytoin, phenobarbital. Maintain normoglycemia, maintain normocapnia. If there is hyperthermia, treat it, avoid it. Consider also therapeutic hypothermia. What is therapeutic hypothermia? In a patient with ventricular fibrillation arrest, if they get return of spontaneous circulation but still they are unconscious, so the body should be cooled to a temperature between 32 to 34. This will be started as soon as possible and continue through the next 24 hours. the body slowly rewarmed after that. You have to give 30 ml per kg of 40 centigrade IV fluid. And also you may do external cooling by ice pack, wet tool, and cooling blankets. And then you also may maintain the internal cooling by cardiopulmonary bypass and also intravascular heat exchanger. This will have many complications, but it will provide a good neurological outcome of the patient. What about the prognosis after cardiac arrest? This would be complex, difficult for everybody to expect, but there is no clinical or neurological signs that predicted outcome before 24 hours after thoracic. No one can say that this patient is surviving or not, even if they have dilated pupil and all signs of bad neurological predicate. So the poor outcome only can be detected after 3 days. So after 3 days, if there is absent pupil light reflex, absent corneal reflex, absent or extensor motor response to pain, it means it is a poor outcome. That's why doctors in the RCU tell the family of the patient, your family will need 72 hours to decide and in order to say good prognosis or bad prognosis. Limited data available for therapeutic hypothermia prognosis, but anyhow, until 3 days, no one can say this is bad prognosis. The organ donation can be instituted if the Glasgow at 4 and 3 after 3 days. So if a patient may need a heart or may need a kidney, you have to do organ donation. In summary, the post-cardiac arrest syndrome is a complex syndrome. The quality of post-resuscitation care influences the final outcome of the quality of the life of the patient later on. Appropriate monitoring, safe transfer, and continued organ transfer or organ support will lead to good outcome. Assessment of prognosis is difficult, especially less than 72 hours after return of spontaneous circulation. Thanks again. Thanks for housing organization. And this was in collaboration between Hawler Medical University and Kurdistan Society of Emergency Medicine. Thank you.